Mortality in the 30 days following a non-cardiac surgical procedure is over 100 times higher than mortality inside the operating room. When looking for the neurological causes of this mortality, we usually look for overt perioperative strokes, but those are statistically rare, occurring in less than 1% of non-cardiac surgeries. This chart compares brain injury incidence in patients over 65. Overt strokes remain below 1%, while covert strokes, infarctions with no outward symptoms, occur in up to 12%. Postoperative MRIs reveal these as multiple 7mm infarctions, concentrated in the frontal lobe. Causing no immediate facial drooping or speech slurring, these infarctions go entirely undocumented on the surgical ward. They are the primary, unrecorded drivers of unexpected postoperative cognitive failure in elderly patients. This visualization tracks the immediate clinical consequences of suffering a covert stroke. Data shows these patients face a 2.18 times increased odds of developing severe postoperative delirium. Extending the timeline to 1 year reveals a 2.33 times multiplied risk of severe neurocognitive decline. For decades, the clinical approach to mitigate this risk was to enforce a static, universal waiting period for all patients with a history of stroke before clearing them for surgery. Modern preoperative assessment replaces those static calendar waits with targeted disability stratification and strict physiological controls. Safely clearing a patient with a prior cerebrovascular accident requires abandoning arbitrary timelines. The decision must be driven by precise, individualized neurological and hemodynamic data. The first step in this algorithmic clearance is quantifying the patient's residual disability. The mandatory tool for this is the Modified Rankin Scale, or MRS, which grades stroke disability from a score of 0, meaning no symptoms, to 5, meaning severe disability. This graph plots risk over time. For MRS 0 or 1, optimal surgery is 14 to 90 days. Under 2 days spikes risk to 3.6%. MRS 3 or 4 mandates a 3 to 6 month delay. MRS 5 holds a baseline 6.5% risk regardless of delay. Crucially, delaying surgery beyond 90 days for the lowest risk MRS 0 and 1 patients offers no additional statistical reduction in perioperative stroke risk. Surgical timing is strictly a function of disability severity. Arbitrary delays unnecessarily postpone procedures for low-risk patients, while rushing the timeline endangers those at high risk. Even when the surgical timeline is perfectly optimized according to the Modified Rankin Scale, the patient's physiological phenotype can independently compound your perioperative risk. The CHA-2DS2 VASC score is a primary systemic danger signal. A score of 4 or higher heavily predicts severe perioperative cardiovascular and cerebral complications. Localized physical blockages further escalate the threat. Symptomatic carotid stenosis greater than 50% is a severe independent predictor of stroke. Systemic organ dysfunction also plays a critical role. Chronic kidney disease with an eGFR below 45 drastically elevates the likelihood of a perioperative stroke. When these compromised patients undergo surgeries involving massive fluid shifts or complex neurosurgical interventions, the mechanical stress placed on their vascular system is extreme. A history of cerebrovascular disease impairs the brain's innate capacity to auto-regulate its own blood flow. It loses the ability to dial its internal vascular resistance up or down to compensate for systemic changes. Stripped of this mechanical defense against the volatile fluid shifts of the operating room, covert strokes become inevitable unless clinicians intervene with precise, targeted management. Once the timeline and risk phenotype are established, the patient enters the active medical optimization phase required before surgical clearance. Baseline blood pressure must be strictly controlled, with a mandatory preoperative target below 140/90 millimeters of mercury. This decision tree outlines the antiplatelet protocol. Continue aspirin therapy for secondary stroke prevention unless the surgical procedure carries an unacceptable bleeding risk. For dual antiplatelet therapy interruptions, stop intervals are 7 days prior for prasugrel, 5 days for clopidogrel, and 3 days for ticagrelor. Statin therapy must be continued. Statins demonstrate proven efficacy in reducing overall perioperative stroke risk and should not be paused. The POISE trial provides a critical warning regarding beta blockers. Clinicians must never initiate new perioperative beta blocker therapy specifically for stroke prevention. Initiating this therapy right before surgery actually increases the risk of stroke 2.17 times. Perioperative medical management relies on maintaining the patient's existing vascular equilibrium. Abrupt pharmacological changes disrupt that equilibrium and directly trigger the cerebrovascular events we are trying to prevent. The focus now shifts to the intraoperative and postoperative environment, the exact locations where these cerebral injuries take place. Intraoperative hypotension is the primary trigger for both acute kidney injury and myocardial injury after non-cardiac surgery, or MINS. This graph tracks mean arterial pressure, defining the absolute intraoperative hemodynamic floor. MAP must remain strictly above 65 millimeters of mercury at all times. Furthermore, there is a relative hemodynamic rule. MAP must be maintained within 20% of the individual patient's specific preoperative baseline. Pre-incisional hypotension represents a severe and often overlooked threat. 1/3 of all intraoperative hypotensive events occur during anesthetic induction, before the surgeon even makes the first cut. Dropping below these precise MAP thresholds results in catastrophic hypoperfusion. The blood pressure is simply too low to push oxygen into the vulnerable watershed territories of the brain. Postoperative vigilance is equally critical. Routine vital checks every 4 hours on the surgical ward miss up to half of all prolonged hypotensive episodes. Strict, continuous MAP maintenance is the single most important modifiable intraoperative variable. It is the only way to prevent a previously damaged brain from starving of oxygen. Even with strict protocols in place, surgical teams must recognize the specific criteria that mandate an immediate halt to the standard clearance algorithm, requiring formal neurological consultation. This flowchart defines the clinical red lines. The first is a timeline trigger. Any patient requiring urgent or semi-urgent surgery who has suffered a stroke within the last 90 days and carries an MRS of 3 or higher. The second is a disability red line. Any patient with severe disability, defined as an MRS of 5, being considered for an elective surgical procedure. Additional diagnostic red lines include symptomatic intracranial stenosis, a history of multiple recurrent strokes despite medical therapy, or an uncertain stroke etiology. Recognizing exactly when a patient's physiology exceeds the safety parameters of algorithmic clearance prevents predictable, catastrophic perioperative mortality. The complete clearance model relies on 3 pillars: verified MRS timeline compatibility, optimized blood pressure targets, and an established, unbroken antiplatelet plan. This projection charts long-term cognitive decline. The outcomes for patients managed with strict hemodynamic and timeline controls remain stable over 12 months. For those subjected to unoptimized clearance, the trajectory points directly towards severe cognitive failure. Covert infarctions are the most common neurological complication for the elderly surgical patient, occurring at 10 times the rate of overt strokes. Careful preoperative assessment, combined with relentless interoperative hemodynamic discipline, neutralizes this hidden threat. Rigorous CDA clearance serves as a precision physiological defense against long-term silent brain injury.